Welcome to the afternoon session. We had a wonderful morning listening to the history of pathology said in the most beautiful way by Dr. Young. For those of you who don't know me, I'm Meera Hameed. I'm the Chief of Surgical Pathology at MSKCC. So we have, as usual, our seminar session has cases which are, even though we are subspecialized, this session is not subspecialized. And before we start, I heard so much about Dr. Scully, which I, of course, never had the fortunate moment to even meet with him. But I had my mentor who actually did his residency at MGH in the 1960s. He told me a story about Dr. Scully, and I thought I'd share with you. I believe when the residents used to make sections of all kinds of things and show Dr. Scully because he knew everything. So they would show him grains, dog meat, or plants, and he would know it all. So one day they took puffed wheat, and they sectioned it, and they gave it to him, and he looked at it, and he said, this needs cereal sections. So he knew it was a cereal. So that's how good he was. But anyway, with that, I will introduce our first speaker, Sarah Chiang. She's assistant attending pathologist, came to us in 2012. So she is from Dr. Scully's MGH and one of theirs, and now she's one of ours. And she's going to start with the first case.
All right. Thank you, Meera. And welcome, everybody. It's always exciting to present an interesting case at the alumni meeting here, and it's especially exciting this year because the recipient of the Fred Stewart Award is Dr. Young, who has been a wonderful mentor to me and a great friend to both me and my husband, who went to the dark side and became a neuropathologist. But when I was a trainee, Dr. Young always emphasized the crucial importance of morphology in our diagnoses, and that, yes, there is this great need for immunohistochemistry and molecular pathology, but the results of those ancillary studies are really the most meaningful and the most informative when we come to the right diagnosis, or at least the right differential diagnosis, based on a very careful and thorough evaluation of a simple H&E slide. So I wanted to pick a case that was a pretty morphology case that I hope Dr. Young does not find mundane, that is very interesting and enjoyable to you all. So let's begin with the case history. It's a 50-year-old premenopausal woman who had symptomatic fibroids. She had a 5-year history of hypermenorrhea with excessive vaginal bleeding with every menstrual cycle. She was put on oral contraceptives and hormonal medications, but continued to have severe symptoms. And so she underwent a hysteroscopy with a dilation and curettage and was found at the time to have a benign endometrial polyp. But despite the surgery, she continued to have continued symptoms of heavy vaginal bleeding, and so she underwent a total hysterectomy with bilateral salpingectomy. So unfortunately, I don't have a nice gross photograph to go along with this case, but you can see here that it involves the endometrium, and if you had taken a look at the slide on a perio, it also involves the myometrium. But here we can see that there are a few scattered residual normal endometrial glands, but the endometrium has really been replaced by a number of cells that are forming small to large, variably shaped nests in the endometrium. And these nests are composed of very bland tumor cells. These cells have round to ovoid nuclei. Some of them are grooved, but otherwise have a very smooth chromatin homogeneous pattern. Occasionally you can see very small nucleoli, and there's no mitotic activity. And they're arranged in this jigsaw pattern. These cells also in other areas tend to form these cords and ribbons, as you see here, and also some trabeculae. They're also associated with a very minor stromal component in the background. And in other parts of the tumor, you can see that the cells become very epithelioid and have this abundant, foamy, lipid-rich cytoplasm, as we can see in this view, that resemble the luteinized stromal cells of an ovary. What was peculiar about this case is that you see these nests of epithelial-like cells that somewhat are intermixed with mature smooth muscle, as you can see in this case. And here's a higher power view of the intimate admixture of these sex cord-like areas and also the mature smooth muscle in the background with very little or actually no stromal reaction whatsoever. So what's the differential diagnosis? Well, the top two, really based on this case, is a low-grade endometrial stromal sarcoma with sex cord differentiation and a uterine tumor resembling ovarian sex cord tumor, based on the amount of sex cord-like elements that you saw in those previous pictures. I think lower on the list is an endometrial adenocarcinoma, particularly when you have a very limited sample like a curetting or a biopsy. But in this case, it's really the predominant pattern of sex cord differentiation and the lack of overtly malignant features that really puts that diagnosis much lower on the differential. So between these two top entities, which one is it? Well, based on the predominant pattern of sex cord differentiation and the lack of any classic endometrial stromal tumor-like morphology, the diagnosis in this case was made as a uterine tumor resembling ovarian sex cord tumor, or UTROS. As you all know, that this UTROS is actually one of the many famous Dr. Scully entities. He and Dr. Clement originally described this curious group of tumors in their publication in 1976. They divided uterine mesenchymal tumors with sex cord elements into two groups. Group 1, which were endometrial stromal tumors, with sex cord elements comprising less than 50% of the overall tumor, and group 2 that had pure or predominant sex cord patterns. And now today we know that group 2 really belong under the term of UTROS, and group 1 tumors are considered now morphologic variants of endometrial stromal tumors. So UTROS can have a variable appearance based on the type and also the amount of the sex cord element that one can see in this funny tumor type. In this example, you can see numerous cellular trabeculae that are arranged in a plexiform pattern. Occasionally, you can see very round and small Sertoli-like tubules that resemble a Sertoli cell tumor of the ovary. Sometimes those tubules can be very solid in appearance. And occasionally, those cells that comprise the solid tubules can have a lot of foamy cytoplasm and appear lipid-rich. And also, these tumor cells can line slit-like spaces and form a retiform pattern, as you can see in this example. And lastly, we can sometimes see a pseudopapillary pattern in UTROS that resemble the pattern that we see in adult granulosa cell tumors of the ovary. And a subset of UTROS actually have this appearance. Most of the time they're well circumscribed, but sometimes you can see that they're admixed with this mature smooth muscle. And Dr. Young and colleagues actually demonstrated this in a USCAP abstract a number of years ago. Subset of UTROS actually have this morphology in which the smooth muscle resembles and may actually be incorporated myometrium and should not actually be interpreted as clinically significant myometrial invasion. So just as they have a varied morphologic appearance, they actually have a polyphenotypic immunoprofile. So they can stain for a variety of epithelial markers, so pankeratin, EMA. They can also stain for smooth muscle markers like desmin, SMA, or HCAL-desmin, although they stain less strongly than what you would expect in like an epithelioid smooth muscle tumor. They can also stain for CD10. CD10 is, of course, as you know, a marker that we often use when we are considering an endometrial stromal tumor. And UTROS can be positive, in this case focally, for CD10, but CD10 is also a nonspecific marker and can stain a number of different lesions. UTROS usually stain for at least one sex cord marker. In this case, it was strongly positive for inhibin and also calretinin. So there really hasn't been, we don't know much about the molecular genetics of these tumors given its rarity. But since there are some thoughts that these may be related to endometrial stromal tumors. One study came from the MGH recently published by Paul Statz, who was a former Scully Fellow who trained with Dr. Young not long ago. They published a study demonstrating that UTROS actually lack the JAS-F1 SUS12 rearrangement that we commonly see in endometrial stromal tumors. Endometrial stromal nodules, the vast majority of those have this rearrangement, and over half of endometrial stromal sarcomas that are low grade also have this fusion. And in their study, they showed in this nice example of a UTROS that we have clear separation of red and green signals consistent with absence of that particular gene fusion. What I thought was very interesting about their study was that one particular UTROS actually demonstrated in one focus amplification of SUS12, or at least a small segment of DNA that includes the SUS12 gene. So even though these tumors lack SUS12 rearrangement that we commonly see in endometrial stromal tumors, perhaps SUS12 still plays a role in the pathogenesis, albeit a different genetic mechanism. I'll also mention here, it has not been published yet, but it was presented by Dr. Oliva and colleagues at the recent USCAP that UTROS also lack PHF rearrangements. Dr. Hameed Pratt several years ago suggested that PHF rearrangements were associated with low-grade endometrial stromal sarcomas that had sex cord differentiation. However, UTROS, since there's an abundance of sex cord differentiation in these tumors, they lack PHF rearrangement. As you heard earlier, FOXL2 mentioned has been found mutated in the vast majority of adult granulosa cell tumors of the ovary. We recently showed that UTROS lack that specific mutation, but as just like other sex cord stromal tumors of the ovary that often express FOXL2, UTROS can variably express this marker as well, despite lacking the common mutation seen in adult granulosa cell tumors. So take-home points from this case and UTROS in general, I think it's important that we recognize them based on their pure or predominant epithelial patterns that resemble ovarian sex cord tumors, and it's also important that we remember that they can have a variable morphologic appearance based on the amount of different sex cord elements that we can see in this tumor type. We should also remember that they can have an admixture of mature smooth muscle that may represent incorporated myometrium and shouldn't be regarded as myometrial invasion. And they also have a very polyphenotypic immunoprofile, so they can stain for epithelial, smooth muscle, and as well as sex cord markers. And there's a lot of things that we have yet to do in terms of research in these tumors. It's a rare tumor type, and we really don't know what is driving this tumor. But what we do know is that they lack the aberrations that are characteristic of the vast majority of endometrial stromal tumors and also adult granulosa cell tumors of the ovary. All right, and that's it for the presentation. Thanks.
Are you going to do any molecular studies?
I'd have to ask Britta. Dr. Michael. It would.
She has looked at them.
She hasn't. You know, these cases are so rare that it's hard to track them down. But Dr. Young and we've collected a number of these cases, and that's definitely something that we should do. I didn't mention in the talk, but actually, back in the day, there were 2 case reports of UTROS, things that were diagnosed as UTROS, that actually had rearrangements. But these rearrangements have not been found in endometrial stromal tumors. So I think it would be very interesting if we come across cases to actually sequence them and maybe do RNA sequencing to find potential rearrangements. Yeah.